Okay. I'm going to talk about some neuromuscular diseases. I'm going to focus really on the first three and the last one that I have listed there. And some of these other ones that are present, muscular dystrophy, multiple sclerosis, cerebral palsy, ankylosing spondylitis, spinal muscular atrophy, SMA, they're all, we treat them all kind of the same. So I'm not going to focus that much on them, but there are other neuromuscular diseases that are rare cases, and a lot of the kids at camp that we'll see have a lot of these other bizarre neuromuscular disorders. But the four I want to focus on: Guillain-Barré syndrome, myasthenia gravis, amyotrophic lateral sclerosis or ALS, and spinal cord injury. There actually was a third guy who was involved in this. His name is Landry. Why he doesn't get included in Guillain-Barré syndrome, I don't know, but he got screwed. So just Guillain-Barré, two individuals who first described the syndrome. So this is an acute key part. It comes in, and usually it resolves. Rapidly progressive form of an inflammatory polyneuropathy. So those areas where the neuromuscular junction becomes inflamed. Muscle weakness is present. Sensory loss to some extent, but primarily it's just muscle weakness. Begins 5 to 3 days after, or 5 days to 3 weeks after infectious disorder. Sometimes surgery, and unfortunately sometimes after immunizations. Good thing to tell you at this point, right? It's a disorder of the peripheral nervous system, though, as far as what is going on. Many other names for it, as you can see there, but Guillain-Barré is kind of the accepted definition. Don't know what causes it. We figure it's an autoimmune response, so it's something where the body kind of turns against itself. It typically follows an infectious process in some fashion. Usually just simply a URI. Can be just some GI flu, can be viral or bacterial, doesn't really matter. This is where I was talking about the vaccination, the swine flu, for those of you who might remember the swine flu. There was a significant cases reported secondary to the flu vaccine, whether it had something within it that triggered it or what. We weren't entirely sure, but it can be there. Multiple organisms that can be of etiology, both viral and bacterial, including some odd ones like mycoplasma pneumoniae, which often will cause just a walking pneumonia. Salmonella, food poisoning, can end up getting it. All age groups. No, close it if you could. Usually it's in the older individuals over the age of 45. Seems to be greater in males than females, although it really doesn't matter. And there's no seasonal clustering, which is an important component, so it can occur at any time during the year. This is a demyelinating pathology where the myelin sheath that surrounds the neurons gets destroyed. And therefore then the neurons do not function appropriately. It's of the peripheral nervous system, so it has to do with nerve transmission to the muscles. And what you end up having is a paralysis. This is kind of graphically what it looks like, where the destruction happens of that myelin sheath, either completely or partially, to the point that there's not good neuromuscular transmission. And if you remember that myelin sheath is that portion which surrounds the axon itself. And just another picture of that sheath in the process. If you get into neurology, you can memorize this stuff. I don't care that you really know. Just know that it's something with spinal muscles that are, or the peripheral nervous system that affects the muscle innervation in the process.
The key thing to remember with Guillain-Barré is it's ground to brain, GB. It starts in the peripheral, in the feet, in the distal phalanges of the hands, and progresses towards the center. Okay? Starts off as just the tingling sensation of paresthesia, numbness, and then gradually progresses to where you lose deep tendon reflexes. You don't have the normal response you should have, and eventually sensory nerve impairment. And as it progresses up, not only do you lose the ability to swallow and cough and gag, you also paralyzes the diaphragm and you stop breathing. Okay. Again, those symptoms prior to development are just normal flu-type symptoms. As it progresses, as the disease progresses, that's where you start seeing that tingling and loss of function. Again, the feet and legs typically are first, and that paralysis is progressive from the bottom up. What we end up seeing is as they lose function, they lose the ability to have an adequate cough, and they end up developing mucus plugging, they end up developing massive atelectasis, secondary to all of that. Usually the paralysis peaks within 2 weeks. It can stop at any point, so it can stop when it reaches their hips and never progress further onward. And it always reverses in the opposite direction. Okay. Often it just remains in a plateau period, and that plateau period can last for weeks. So they can get to that maximal amount of paralysis and stay there for 3-4 weeks, month, and then it gradually resolves. Initially, you're going to see that hypoxemia is present. Their ability to manage that, especially as the disease progresses, is not good, so they end up developing respiratory failure, and your classic elevation in CO2, fall in pH, fall in PO2. It is a restrictive disease, although it's not something where the lungs necessarily are the problem. It's just that the musculature that innervates it to form ventilation is impaired. And breath sounds would obviously be decreased also. Neurological symptoms are what really drives this, and that's how it's diagnosed, is more along the fact that they have this progressive paralysis. There are some other studies that can be done. They can do a spinal tap and look at the cerebral spinal fluid, and it'll show an increase in protein content where ordinarily you wouldn't see that there. And there's also some electrical diagnostic studies, EMGs, that can be done to see if the nerves are being, or the muscle is being innervated. Again, not a pulmonary disease, so chest x-ray looks fine until the disease progresses. You know, I have not seen MRIs used for this, but I would imagine it would pick up the same, that you would see the loss of muscle tone. With that atelectasis, obviously they're going to have those radiopaque areas. 50% of the cases have some nerve involvement, both sympathetic and parasympathetic. The parasympathetic would affect more of the ability to have bladder sphincter control and bowel control. So obviously this is going to be somebody who's going to need a whole lot of care.
Is this something that might never reverse?
Yep.
Okay.
Yeah, there are some where post Guillain-Barré it just never fully resolves, and they're wheelchair bound.
How does the myelin sheath like repair itself once it's damaged?
It just does, yeah. And again, the degree to which you have total destruction of the myelin sheath will dictate how much of the reversal you end up having. Obviously, for our purposes, there's a couple of key facets that I want you to be aware of. One is that you're going to probably need oxygen therapy because they're hypoventilating. We're going to monitor these patients quite closely with those things that Mary was talking about. Mary went through MEP and MIP, and vital capacity, and maximal inspiratory vital capacity. We're going to monitor these quite frequently, to the extent that it's like every 4 hours we're going in and evaluating them, because we're going to be the people who are going to pick up on the fact that they're into ventilatory failure far before a blood gas will end up doing it. Again, pulse oximetry, especially continuous pulse oximetry, not just spot checking, to be able to evaluate for that deterioration. And then eventually, if it progresses in the normal fashion it often does, these patients are tracheotomized and mechanically ventilated. Some of the other things we might use in the meantime, a hyperinflation protocol. They may not be able to actively take a breath in and take a deep breath. So incentive spirometry might not work, but there are some other mechanisms we can use to promote hyperexpansion. They're definitely going to need bronchial hygiene. If they can't cough, facilitating a cough for them, perhaps even doing nasotracheal suctioning prior to them being intubated or trached. They're at high risk for developing a PE because they're paralyzed. So there's all kind of other stuff that is done for subcutaneous heparin and passive range motions. They're again unable to turn themselves, so they're prone to bed sores, prone to infection secondary to that, and because of the same immobility, they're often developing pneumonia. We talked about their incontinence, so they're going to need urinary catheterization. If there is any cardiac dysrhythmia secondary to hypoxemia, that might need to be addressed. And one of the therapies that is done is plasmapheresis, where they separate out their plasma, replace it with someone else's plasma, basically, and reinstitute that mixture back into the body. The idea here is that the antibodies that the person has might be contributing to the worsening of the paralysis. And the key part here is to look to our pulmonary function measurements to be able to identify patients that are at risk and need to be ventilated. Somebody know what the normal vital capacity is in cc's per kilogram of vital body weight? Didn't think so. It's about 60 to 75. Okay, so about 70 cc's per kilogram, 70 kilogram person, that's 4,900. That sounds like a normal vital capacity. Okay, so when we start seeing values below 10 to 15 cc's per kilo, that's an indication that this person doesn't have the functional reserve to generate a deep breath and a cough needed to facilitate pulmonary function. So 10 to 15 cc's per kilo, time to say, okay, we need to intubate you and ventilate you. A maximal, go ahead.
Like it says, if V-seam decreases to 10 to 15, or is it if respiratory rate increases, either or it's both of them?
You're probably going to see all of them together. So somebody who can't take a deep breath is going to be breathing faster. Okay? And their ability to generate a maximal pressure is impaired. Because remember, the maximal inspiratory pressure, maximal expiratory pressure are dictated by the respiratory muscles. So as that musculature's innervation gets impaired, they can't generate a big breath, you're going to see that going down. This is out of Egan, I believe, someplace, and it's a really nice little chart that is there. Normal, we said, was above 65 to 75, and it kind of says what goes on as far as our interventions and what kind of respiratory pathophysiology you would end up seeing. And you could see that as you have a reduction in vital capacity, you have a poor cough, secretions accumulate, your ability to take a deep breath is impaired, so you end up having atelectasis and refractory hypoxemia secondary to the shunt effect. Getting worse, hypoventilation, hypercapnia, death. And as you go down, you can see the different things that we might need to intervene with. But again, that 10 to 15 cc's per kilo is an important part to remember. Most cases, 85 to 95% of them have a recovery and everything's fine. But again, there is those that don't have full recovery, and there is some residual weakness which is present. And that improvement may take a while, okay? Let me pause and tell a little story here for you.
Look at this guy. One of the ones you always remember. So that's Guillain-Barré.
ground to brain. Myasthenia gravis, we're going to find, is a paralysis in the opposite direction. This is something where the receptors for acetylcholine kind of have a problem with transmission of that neuromuscular transmitter. This is a chronic disorder. This is something that the person has, and through medication it's kept in abeyance, but there can be crises that end up happening. But it's something that it's not something that goes away, okay? It's more associated with voluntary muscle than it is with anything else, and it seems to be triggered by stress and fatigue, and when those are relieved, the person's fine, okay? What it goes on is that there's some anti-acetylcholine receptor antibodies that circulate through the body and inhibit the ability of that neuromuscular transmission to occur, and the receptor sites involved. This is one where a gland known as the thymus gland seems to have the origin of where these antibodies come from. So removal of the thymus, as we'll find, is something that is done. More common in females than in male, especially in young females, which is kind of interesting. Males, if they get it older in life, but it's like I said, far more common in females. The signs and symptoms seem to be provoked by events that happen that are stressful. Things that cause emotion, breaking up with the boyfriend, job change, pregnancy. It's not necessarily something which is mortal, but certainly does have mortality associated with it. Some groups of muscles which are involved, the eyelids are one of the key ones, and because it does cause a generalized muscle weakness, it can affect the diaphragm and affect ventilatory failure. And again, what we're talking about here is where these acetylcholine receptors are present. There's something that block these anti-acetylcholine antibodies, block those sites and prevent the neuromuscular transaction to happen. So again, something blocking that acetylcholine site.
Can they have memory loss? Like
I've never seen anything as far as memory loss with
this
them.
one or the other one?
Or the other one, no. No, it's more just muscle. Yeah.
Is it anything like Epstein-Barr? Where you get like the
Epstein-Barr is... Epstein-Barr is just a general muscularized weakness.
Right.
This is more specific to certain groups of muscles. Although it can affect everything. You usually see it in the face first, as we'll see. Ptosis, where the eye muscles become weakened and they have a hard time keeping their eyes open. Extraocular muscles, so they end up with blurred vision, double vision. Muscles of the face, so they end up having problems with speech and chewing and swallowing. And like I said, peripherally, you'll end up getting some in the arms and legs, and in theory at least, even the diaphragm involved. This is a descending paralysis, mind to ground, if you want to think of it that way. MG, myasthenia gravis. So the other one was ground to brain. This is mind to ground. A gradual onset. Usually the first symptoms you end up seeing is a drooping of the eyelids. I think a lot of times students in my class end up having this. So. Yeah, but it's not. It's a lot of the voluntary muscles that you end up seeing more so. There is a special type which just affects the eyes, and that's called ocular myasthenia. We're not going to concern ourselves with that, so you can ignore it. But again, it's primarily in the upper face and neck that you end up seeing the inability. And I have not heard that it led to blindness at all.
So you just can't see one direction.
Or it's blurred vision. But as far as actual loss of sight, no. I have not heard that. If it progresses, to, the weakness extends to the peripheral muscles, you'll end up having problems where walking and lifting are problems. Usually it's not painful, and their deep tendons do remain intact. It's more just this generalized weakness that ends up happening. And again, they could be perfectly fine, and it's only during these stressful times that the symptoms happen, and often because of the stress through the day, it's at night that they end up seeing some of the symptoms developing. And again, we talked about the diaphragm getting involved. Again, looking at this, it's not a lung disease, so unless there's some involvement where the diaphragm is impaired, you probably will end up seeing. It's usually the secretions and the loss of cough function and swallow function and leading to aspiration that is more of the problem that we end up seeing. And again, if it's severe enough, you're going to see ventilatory failure with hypoxemia secondary to hypoventilation. Again, you don't see that often. It is considered to be a restrictive disease, again, simply because of volume, tidal volume might be diminished. It's primarily made on diagnosis on clinical history. There is a specialized test that can be done to be able to identify the presence of myasthenia gravis, and it's called the tensilon test. Tensilon, or edrophonium chloride, let's start by that one, is an anticholinesterase, so it prevents the cholinesterase from breaking down acetylcholine. And we'll talk about that in a half a sec. You can also look at EMGs, you can measure the circulating antibodies in the blood, and often, especially during crisis, you'll end up seeing the thymus gland enlarged. Here's what the tensilon test will look like. You can see this individual has some loss of eye muscle function. Give them some tensilon, and within a few minutes, it's totally resolved. So it's that fast as far as a reversal process.
It looks like Bell's palsy almost.
Yeah, but Bell's palsy sticks around. This doesn't.
Right.
Yeah. Yes, as far as the manifestation, yes. Just so we're clear, the thymus gland is not the thyroid gland. Thyroid gland is located in the neck. Thymus gland is located in the mediastinum. Okay? And they manufacture those T lymphocytes, and they also, when it goes awry, creates these antibodies. Management, again, they're real. As long as it's managed with medication, it's live a normal life. When those exacerbations do happen, the most we would end up probably needing to do is just monitoring their pulmonary function through vital capacities and maximal inspiratory pressures. Perhaps they might need ventilation, but again, that's a rarity. They're typically on one of these anticholinesterase drugs, so they're on a low level of tensilon or prostigmine, pyridostigmine, as far as a medication. They might be on steroid therapy. That's why that works, I'm not entirely sure. And the adrenocorticotropic hormone therapy is another therapy that is utilized with it. But what I want you to remember is those anticholinesterase is the way we end up doing it. Especially in young females, the removal of the thymus gland makes sense. I mean, you have a problem with immunologic response, but again, just like removing the spleen, if it's damaged, you can still live a normal life. Same thing here. Extreme cases can get that plasmapheresis again, where we remove the antibodies by removing the plasma, separating it and removing it. And from our purposes, the most they might need is some bronchial hygiene and hyperinflation for any atelectasis. Now, there is a specialized situation I want you to be aware of. And it's a distinction between a myasthenia crisis, which is basically an exacerbation of the disease, and in that case, usually giving them some tensilon will reverse the process and they're back to normal. And what we need to do then is just up their dose of drug, okay? And something where they've taken too much anticholinesterase drug.
Either it hasn't been reversed, or hasn't been excreted, and it hangs around longer. And so that's what's called a cholinergic crisis. Okay? And in this case, giving them Tensilon doesn't do anything. And may actually make matters worse. In that case, what you need to do is give something that reverses all those anticholinesterase drugs, a drug like atropine. But left unchecked, they can end up going into cardiac arrest. Okay. So the key part is if they have signs and symptoms of a myasthenia crisis and you give them Tensilon and it doesn't work, that's an oh shit moment. Okay. I'm not sure what that means. Holding cows. I think I'll stop there. We'll pick this up next time. Talk about some other ones.